Good afternoon. Can you hear me? Good. So I think for the sake of time, we'll go ahead and start. I'm going to make a brief welcoming remark, and then Dr. Lee will do the formal introduction. For those of you who may not know me, I'm the Elias Siraj, the Chief of Endocrine Division. It is an honor for us to host today Dr. Mike Tuttle, a speaker for the Dream Speaker Series at the Medical Grand Round. This program, the Dream Speaker Series, was started a couple of years ago to encourage our trainees, residents, and fellows to nominate nationally, internationally renowned speakers. And with the support of Dr. Qayyum, our department chair, whom I don't see here for now, we were able to sponsor him. This year's nomination came from one of our fellows, Amna Kamran. I would like to recognize her. And her nomination ended up winning. So we have Dr. Tuttle with us. It will not be an exaggeration if I say Dr. Tuttle is a rock star in the thyroid community, nationally and internationally. So leading the thyroid cancer arena for decades. And we are very honored to have you. And I will have Dr. Leap do the formal introduction. Dr. Leap.
Thank you, Elias. A double introduction. I don't know how often that happens. So we want to thank Dr. Tuttle for coming, especially after being through the 9th largest snowfall in New York City. So thank you for being here. So welcome everybody to EVMS Internal Medicine Grand Rounds. Today's session is our special Dream Speaker Series, as Dr. Siraj mentioned, which highlights outstanding visiting professors nominated by our residents and fellows. Last year, we were fortunate to host Dr. William Young, former chair of medicine at the Mayo Clinic, who talked about adrenal disease. And this year, we're proud to welcome Dr. Michael Tuttle, nominated by our senior fellow, Dr. Kamran. And I think it's okay that we've had 2 endocrinologists in a row for the Dream Speaker Series. We'll have to keep that trend up next year. So I also want to thank some of our guests in the room today, including colleagues who participate in the EVMS and Centera Multidisciplinary Head and Neck Tumor Board, where I've been proud to serve as the endocrinologist for 17 years. Which is kind of crazy. Dr. Tuttle is professor of medicine at Weill Cornell Medicine and chief of the endocrinology service at Memorial Sloan Kettering Cancer Center. He completed medical school at the University of Louisville, trained in internal medicine at Dwight David Eisenhower Army Medical Center, and completed his endocrine fellowship training at Madigan Army Medical Center in Washington State, I think. For many of us, Dr. Tuttle is a monumental presence in the world of thyroid cancer. He's helped shape national standards of care through major guideline and consensus work. He's published across nearly every area of thyroid cancer. For the residents, fellows, and students who are in the room, if you've looked something up about thyroid cancer and up to date, Mike has written it. And on Tumor Board, whenever we face a very specific high-stakes question, whether it's a nuanced management decision, an uncommon scenario, or a new molecular alteration, more often than not, Dr. Tuttle has already studied, published it, and helped translate it into practical clinical decision-making. Among other things within the world of thyroid cancer, he's known for developing and validating the dynamic risk stratification approach that clinicians rely on for thyroid cancer follow-up. It's really the framework that helps adjust risk over time based on response to therapy, and it guides the intensity of monitoring and treatment in the clinic. Today, Dr. Tuttle will provide updates on thyroid cancer for the internist. Please join me in welcoming Dr. Tuttle.
They wired me up. I'm good. Thanks, David. Fantastic. Thank you so much. I fell for the Dream Series because you can be old and still have a big ego. Because I'd promised my wife I was going to slow down and not travel so much, which is true till I leave tomorrow night to go to Brazil to give a series of lectures. So I promised her I'd be able to get back through the snow tonight, which we're going to be able to do. Plus, I feel like I'm a part-time Hampton Roads resident. The first week of July, every year for the last 20 years, I've been bringing my family down to Sandbridge. So we hang out on the beach down there. So when I told her this had something to do with Sandbridge, if you see her, I told her the medical school was on Sandbridge. Okay, so if you just lie to her, that'd be really very helpful to me, which is where we are. So this morning, I'm going to talk a little bit about thyroid cancer, And I'm going to talk more about how we take care of patients. I'm a clinician. Yeah, I do research, and yeah, I write papers, and I love to write up to date. But if you look at almost everything we've written, it's absolutely out of the clinic. There's a reason a lot of the stuff that we write is stuff you guys are dealing with, because it's the same thing that we're dealing with in our tumor board. I just have the luxury to have a database of 8,000 or 10,000 thyroid cancer patients and a bunch of thyroid cancer fellows who can do the work while I travel and have a good time. So we have that data to be able to do. So I'm going to talk today, really, the theme of it is going to be, how do you deal with a patient when there's clinical equipoise? When there's two right answers. Two right answers in thyroid cancer happens a lot because we don't have any prospective trials. But whether you're doing GI or whether you're doing pulmonary, whether you're a brand new intern, no matter what you are, there are situations where you have to go in the room and say, there's kind of two right answers. What do you want to do? And one of the patients years ago said, what do you mean, what do you want to do? I'm paying a lot of money for your consultation. You tell me what to do. And other people want to have a shared decision. So we've got a review article coming out in New England Journal in about 2 or 3 months, whenever they get done doing all the artwork. And it's going to cover this same sort of general topic. Now, what we're going to do is we're going to start with a case, because sometimes it's easy to be a doctor, a little harder to be a patient. So I'm going to put you in an uncomfortable position, make you a patient. We're going to talk about sort of a really typical thyroid cancer that you may hear about in your practice, not a weird one. A young lady with the first cancer of her life being a low-risk papillary thyroid cancer. I'll use that as my example. We'll talk about that. Then we're going to talk about sort of how we work through the multiple right answers this young lady might have. Now, I don't have any financial disclosures, because when your whole career is minimalizing care and trying to de-escalate care, surprisingly, nobody wants to pay you to de-escalate care. Somebody should have told me that 20 years ago, but it helps me. Why do you think I write all the up-to-date chapters? I can't get a disclosure to save my life. But since you don't know me, you got to understand my personal bias. I strongly favor minimalistic management options. You'll notice your two surgeons in the room were not stunned at that. I've spent my life talking about lobectomy, right? And then when lobectomy was too much, just watching and don't do surgery, and then turn the stupid ultrasound machines off, because you're going to find something I don't want to know about. It's not going to hurt the patient. Never mind. I believe that less is often more, that we do too much many times. And I don't really think there's one right answer most of the time. Most of the time, I think there's more than one right answer. And it's our job as clinicians to help that patient figure out what's the right answer for them, not what's the right answer on the test of something that I wrote. And you'll hear me often say, do just enough. When you talk about de-escalating, particularly, I live in the world of cancer, right? My entire practice is thyroid cancer. I see 60 or 70 thyroid cancer patients a week since 1999. That's all that I know. My wife says, unless you fall and hit your thyroid, I am no help whatsoever. The kids get sick, they don't call me, they call the neighbor who's a pediatrician. But in that little world of thyroid cancer, it used to be you're going to get this massive surgery unless you don't really need it. But I say, no, do it the other way. You're going to get a minimalistic surgery unless you need more, right? That's the other way to look at it, which is where we go. So this is you now. So you get an accidental ultrasound. Everybody gets an ultrasound these days. I saw somebody on Friday that the doctor thought she was hypothyroid, so she got an ultrasound. Okay, cool. And then I saw one, don't do that if you're new here. And then the next one had a carotid ultrasound because they're old like me, and they found a thyroid nodule. And then one of them had a car wreck, and the CT scan found a thyroid nodule. Entirely asymptomatic, and got down this pathway. Somebody sticks a needle into this little 4 millimeter place that we have here, all these little dots here. That's the papillary cancer in the thyroid, and it's a papillary thyroid cancer. And I'll just ask you what you want to do, because half of this room has already decided what you want to do. How many people have already decided you want to have surgery? It's cancer. Don't you lie to me. Thank you. I'm a Kentucky boy. I know I'm supposed to be a Yankee, but don't give me that crap. I grew up in Kentucky. I know Virginia people. How many people are going to say, get this out of my neck right now? Okay. Yeah, exactly right. How many people are going to say, now, well, wait a minute. I read in the paper that maybe not every little cancer needs to be treated. Maybe we're overdiagnosing. So maybe we could watch for a little bit. And then how many people say, get more information? Yeah, good. We have one honest person. Fantastic. We'll hire you for the endocrine fellowship. That's great, unless you happen to be an attending already. I never know. Now, so we'll come back to your case here in a minute, because I'm going to give you some more information. We're going to sort of think through how we take care of this. I will tell you, in our practice at Memorial, with that exact same presentation, half of the people choose surgery or some sort of thermal ablation, and the other half choose to watch. You can't be a bigger fan of not doing anything than my program. Like we have t-shirts, we'll give you handouts, we'll give you a cup that says active surveillance, not really, but we are huge fans of watching. And despite that, half the people will still choose surgery. Now, let's learn a little bit about thyroid cancer. A very typical thyroid cancer is asymptomatic, 29-year-old female. Sometimes these get felt by GYN doctors. GYN doctors are particularly good at feeling thyroids because that's what they do all day of their lives, every day. Other times these are incidentally found. If you look at the list of cancers, we're like number 12. It hangs around there somewhere. We diagnose about 40,000 cases a year. That's not a lot nationwide when you compare the 300,000 up there with breast and prostate. But if you look at how people do, this is what we ran into several years ago. Louise Davies from Dartmouth brought this to our attention right here about 1999 or so. And she said that thyroid cancer is going up. What's causing this rate of thyroid cancer? Look at these numbers. We're going from 5 per 100,000 to 15 or 20. I can show you a graph in this from Korea that goes up to 70. So did the world get exposed to something that caused thyroid cancer? And what's the answer? Well, the answer is kind of yes. It's called an ultrasound machine. And it's called biopsies. And we were now finding all this low-risk thyroid cancer that we didn't know about before. And then when you find it, you find one in a patient, then you're going to order another ultrasound. You find another one. Because we all know finding thyroid cancer is a good thing. Because cancer should be treated and should come out of your body. But if you look at most of those thyroid cancers, they were really small. They were asymptomatic. They weren't causing any symptoms at all. If you look at it, Keith Heller, who's a famous surgeon from up around us years ago, Keith described this as we move from the age of palpation to the age of detection. To the young people in the room, you see this up here? This is called a physical exam. Imagine that you can't turn an ultrasound machine on, or you can't order blood tests or whatever we do. This actually worked really well because this is all I did for the first 10 years of my career. We had 100% survival. This is all I did for the first 10 years of my career. We had 100% survival. So was it some unmet need that brought us all of this junk? Now, I love this junk in people that need it, that have aggressive thyroid cancers and disease that's the palpable stuff that we felt, where I need this staging. It's fantastic for the surgeons to be able to plan their surgeries, both maximalist and minimalist. But what we ended up rolling into is that we found all this clinically insignificant thyroid cancer. So it's all of the iceberg that's underneath. And in fact, if you look at these numbers, it's about 10% of US adults. 1 out of every 10 people sitting in this room has thyroid cancer. David knows that, so he has a small ultrasound unit sitting right outside the door. You can get an ultrasound as you leave. If you think about that, that's about the same number of people that have diabetes. Could you imagine if we diagnosed all this thyroid cancer? We all know tons of people with diabetes. We don't know very many people, but that's the underlying, and this has been shown in autopsy studies. If you take a thyroid out for benign reasons, 10% of the time you find a small papillary thyroid cancer. So we're firmly in this overdiagnosis. Now, even in the earlier days, if you look at how people did, this young lady, 98.5% 5-year survival. But in fact, when you look in young people, that survival rate, the death rate is more like 0.7%. And if you look at the localized one, we're 99.9%. In Manhattan, if I ask you to come down and see me for an initial evaluation of your thyroid cancer, you have a greater risk to your life from transportation than you do from the cancer. I had a slide at one time that showed the likelihood of dying if you came to see me every 6 months for 5 years. And I showed it to my wife, and my wife said, "You really can't show a graph that shows that people are dying because they come to see you." I thought it was funny. The memorial lawyers did not find it amazing at all. Well, the interpretation then should be our treatments were very, very effective, right? Because this is data from the 90s and 2000s and long before we were doing all this little stuff. So the interpretation of a 99.9% survival rate would be our treatments work, right? That's what I had to push back against. Because if you look, our usual treatments, we take the thyroid out. So thyroid lives right up here. Take the thyroid out. If there's involved lymph nodes, those come out that we can see them. In the past, everybody got radioactive iodine. I used to be in the Army, so I call radioactive iodine my heat-seeking missile. You swallow a little bit of radioactive iodine. It goes everywhere through your body. Thyroid and most thyroid cancer needs iodine to live. Every other oncologist would love to say, swallow this. It goes straight to your cancer. That's not what chemo does, right? But that's what radioactive iodine does. So it should work. And these are people that have lung metastasis and a bone metastasis and lung metastasis. And then we keep the TSH nice and low because we've all learned that TSH is called thyroid stimulating hormone. And if you've had any thyroid cancer hiding around, you probably don't want excess thyroid stimulating hormone. So we would keep the TSH nice and low for as long as we could. And then we have these phenomenal blood tests. Thyroglobulin is a blood test marker. It's only made in the normal thyroid in thyroid cancer. That's it for your entire body. So if the surgeon takes out your thyroid, you use radioactive iodine to destroy anything that's left, the thyroglobulin should be what? I will wait you out. Undetectable, right? Should be undetectable. And now we have assays that measure this all the way down to 0.1. Ultrasounds, you shouldn't have any disease left in the neck. You should be able to find it there in the neck. The trouble is these tools have now gotten so good, I apparently can't cure anybody. Because remember, my definition of cure before was I just felt your neck. You came in, I felt your neck. We talked about the kids, we talked about the grandkids, we talked about you're going to donate to my research. All of those really critical, important stuff we need to talk about in an academic center, and the patients did fine. Now, somebody's worried that their thyroglobulin went from 0.1 to 0.2. Can I get an amen from the endocrinologist? Yeah, your 5-minute visit just went to 30 minutes and an epic chat 3 days later, right? Because it doubled. I know, welcome to my life. Now, if I'm honest with you, I finished my fellowship in 1993. Yes, for the young people in the room, that would be the last century. I wish that was a joke, but it's not. So I started practicing in 1993 and did my first set of guidelines with the ATA in about 2006. And I had no less confidence in 2006 than I do in 2026. That didn't make me right. It just made me confident. And here's what we wrote back in 2006 for this 1.5 centimeter tumor. Largely felt by palpation, because we weren't doing a lot of screening ultrasounds and stuff back then. She would have definitely got a total thyroidectomy, maybe some lymph nodes taken out, definitely would have gotten radioactive iodine. We'd have put the TSH all the way down to barely detectable. It was a one-size-fits-all management approach. And back then, we said we did shared decision-making. And the way that works is I made a decision, and I shared it with you. That was shared decision-making. Now, if you look at that exact same patient in 2015, so jump 10 years ahead, the new guidelines in 2015, we're now finding we're in the midst of this rise. We're finding all this microscopic thyroid cancer. Now we're saying, well, maybe you can take out half or the whole thyroid. And we're saying, well, you don't really need a neck dissection for lymph nodes. Maybe you need radioactive iodine. TSH, well, we won't let it get very high. We'll keep it a little bit on the low side. We're doing better at risk adapted because we're saying, you know, what I learned in 1990 treating big thyroid cancer doesn't really feel like it applies to your 4-millimeter papillary cancer, right? That just feels like overtreatment. And then if you look at the newest guidelines that were out, 24, 25, now at least in New York, we have lots of people getting cancer screening. There are freestanding centers that will scan you from the top of your head to the bottom of your feet with MRIs. You guys have those down here? MRIs and ultrasounds and whole 9 yards. And all they're finding by and large is tons of false positives, and we're chasing and we're doing biopsies, but we're seeing more of that. And in fact, we've gone now to 2004 for data that I'll show you. You certainly don't need a whole thyroid and radioactive iodine. Now maybe you just need half your thyroid, or lo and behold, maybe you don't need surgery at all. In the course of my lifetime, in the course of the time that I've been practicing thyroid cancer. So it's always interesting to say, how did we get there? How did we get from 2006 where we were confident that everybody needed all this stuff and everybody was doing great? I often show a slide of a farm I grew up on in Kentucky with a rooster crowing in the morning and the sun coming up, and make the point that the rooster thinks he makes the sun come up. Guess what? Sun was coming up anyway. So I took credit in 2006 for curing all these people, and the surgeons doing meticulous surgery. And then by 2015, I'm like, well, I'm curing the ones that really need to be cured. And by 2024, I'm like, okay, I'm retiring because it's not clear I'm doing anything. That maybe what I was taking credit of it was for the natural history of the disease. That'll hurt your head. Maybe all this extra treatments wasn't doing anything when the natural history of this disease was not to hurt these patients. Now, not all thyroid cancers. There's lots of thyroid cancer that needs to be treated, but this low-risk stuff we need to take a look at. It's not unique to thyroid that you have a sort of a medical reversal. This is a really interesting series from Prasad and them. They've written several books and several articles and ask, why do we change our mind? And in this, 146 published in New England Journal. Now, if they're New England Journal, they got to be right? I mean, that's what they tell us. And we all try to get our stuff in New England Journal. That was the first thing I led with, right? I've got a New England Journal paper, go read it. Doesn't make it right. And they looked at it between this time frame. And what they said, this is where articles came out and said, hey, we changed our mind. Not newer or better therapies, or not some landmark study that changed it, but a reevaluation of what we were doing. And began to ask, why was that? And there were two kind of big reasons. One, reversals happen when a practice is adopted before it has a strong base. And it's usually coupled with, it has to work. Common sense says it has to work. This happened in the 1970s in thyroid cancer. In thyroid 1970s, we learned we could use radioactive iodine very safely. And I already told you it's a heat-seeking missile, right? So why would we not give everybody radioactive iodine? Just common sense said that. And if I'm doing that, now the surgeons have to take the entire thyroid out, because radioactive iodine doesn't work if there's any normal thyroid. So that common sense decision led by Dr. Mazzaferri, who was one of my mentors, led to us giving everybody radioactive iodine, and the downstream effect, everybody got a total thyroidectomy and the complications of surgery. Now, when we look at sort of what's happened over the last 10 or 15 years, it's the circle of life. We've gone from lobectomy to total thyroidectomy back to lobectomy. We've gone to prophylactic neck dissections back to no, you don't have to take out all those little lymph nodes. We've talked about radioactive iodine and even the treatment of minimal residual disease. I showed you the ultrasound and the blood test finds new cases, but it also finds persistent low-level microscopic disease that likely is never going to hurt anybody. And yet we spend 10 years doing more surgeries and more radioactive iodine. So that common sense thing can get you in trouble without any trials. I'm going to show you an example today that I hope doesn't get overturned, and we're going to talk about watching little papillary microcarcinomas, small thyroid cancers with just observation. There's some data on this. Remote access stuff to the endocrinologist, redifferentiation where we have ways to make radioactive iodine work better. Neoadjuvant in thyroid cancer where we know the target of the tumor and we put them on a targeted drug to kind of shrink the disease before it. Thermal ablation with radiofrequency ablation. All of these are on the list of stuff that this really ought to work. And this really ought to help people logically. But in the absence of prospective trials, we have to keep in mind these might or might not work. Endocrinologists as a group, we love feedbacks and we love mechanisms and we love logic. We are uniquely situated to fall into this trap. Because if it makes sense, I can't tell you the number of times at a national meeting, I'm just like, that's the way I do it. And it works. Next question. And then try to do a paper or something. But makes us be willing to kind of reevaluate. Now, many times when we're sort of talking with patients, we're trying to figure out what's the best thing to do. A large part of my practice is secondary and tertiary referrals. They've seen really good people all over the country, and then they come up. It's you guys, the same thing Bill Young told you last year, but just for adrenals, right? Neither Bill nor I see normal people. We see second and third and all these kind of weird recurrences and stuff. And they often come in and say, tell me what to do. One doctor told me to do this. One doctor told me to do this. Who's right? And when I won't tell them, they'll go, look, secretly, we're not going to tell anybody. I'm like, yeah, I've seen you on Facebook and MySpace. Is that what you still use? I don't know, something like under treatment and over treatment we're trying to avoid. And they want to know the one single answer. But I think more appropriately, we should think about a range of options that are not over treatment or under treatment, but a range of reasonable options that may be suited to an individual patient. Now, you've probably already figured out I use my voice for a living, right? This is what I do for fun. This is what I do for a living. This pays me a lot of money. If you do anything to me that changes my voice, we got a big problem, right? If I've got a hoarse voice or a paralyzed vocal cord, you've absolutely changed my life. You better be saving my life if you do that to me. But if you treat me for something that doesn't need to be treated, and so to me, my values and the stuff that's important to me, you're going to have a hard time talking me into doing any surgery around my voice box, unless you're going to convince me that it's going to really, really hurt me or I'm going to really, really die, right? My wife is the opposite. My wife, for reasons that are unclear to me, still has an incredible faith in the medical system. And she's convinced that all of my surgeons that I work with are the best in the world. And she would just pick out the best surgeon to be done, right? Her value is get cancer out of my body. As soon as the cholesterol goes up 1 point, give me one of those cholesterol medicines. I don't use those things. Diabetes, as soon as it gets that, right? As opposed to the other people who are more like me that go, okay, I know my blood sugar is a little borderline. Swear to God, I'm going to get on my diet. Swear to God, right? Say amen. Blood pressure is a little bit high. We know those people, right? So that is sort of cooked into sort of how they think about stuff. So if we think about this young lady at a 1.4 centimeter, she would actually have the choice of active surveillance. We used to just watch things less than a centimeter. Now we're easily up to 1.5 centimeters. She would have the option of taking out just half the thyroid, or she would actually have the option of taking out the whole thyroid, depending on the details of her case. Now, the same sort of range of management options, I always think about it in terms of thyroid and thyroid cancer, but if you're doing something besides thyroid, you're thinking about other therapeutic options, right? Whether it's osteoporosis or diabetes or everything that we're dealing with, where there's not like a randomized prospective trial to take a look at. So in a little one like this, if I come back to you and I say, let me tell you a little bit more about this sort of minimalistic management approach, and then we'll come back to the young lady. This idea of watching thyroid cancer actually started in Japan about 30 years ago. Akira Miyuchi is a surgeon from Japan. He was the first person to bring fine needle aspirations to Japan in the 1960s from up in Scandinavia, the big clinic where they do them up there. So he went up there and learned and brought it back. He actually also owns his own hospital. So apparently, if you own your own hospital and you have 10 surgeons that work there and 1 endocrinologist, and you go to a board meeting and take a vote on, can we just watch this or do we have to treat? Yeah, you would think the vote would be 10-1. Not a chance. That endocrinologist voted with the surgeons. So 11 people said, let's just watch these things. Because he knew the complications. He was a phenomenally talented surgeon. And his heart of heart, he says, we're just hurting more people than we're helping. Why don't we just tell them to watch for a little bit, less than a centimeter confined to the thyroid? And in fact, they've been doing this for 30 years now. Even in his center that was dedicated to watching, half the people would choose to watch. Half the people, sometimes they tell me, nice chat. That was a really, really good discussion. When can I meet Dr. Shah, your surgeon? I'm like, I just spent 30 minutes trying to help you out here. And the other thing that he showed very nicely is we call this salvage therapy. Now, I don't really use the term salvage therapy to patients because salvage feels like I've ripped them back from the jaws of death. But we all know what we mean by salvage therapy, right? Shah, my surgeon, calls this delayed therapy, that the outcomes are just as good if you're in that 5 or 10% that grow. I can treat you just as easily. And we'll talk about it in a minute. I may be able to treat you more appropriately if you give me 6 months or a year or two to figure out what's going on with your thyroid cancer. And is there cancer on the other side? And is it in the lymph nodes? If you give us a little time, we'll probably be able to give you a better idea about whether you need surgery, and if you do, what that surgery would look like. I went over to Japan in 2012 because we were running into the same thing at Memorial. My surgeons were very open to a watching program. So I went to Akira's shop and spent a few days with him and literally sat for hours, and he showed me ultrasound after ultrasound after ultrasound of people he's been watching for 5 years, 10 years, 15 years to convince us that there is nothing special about thyroid cancer in Japan. I now have a slide that says thyroid cancer is not racist. It doesn't care where you're from. So you'll see studies on here everywhere from ours up here to Korea to Japan to Colombia. Dr. Sanabria is down in Colombia, Argentina, Pisa, Italy. And you find basically these same things. Tumor sizes, everybody started out at 1 centimeter. I tend to push the edge, so we've pushed up to 1.5 centimeter. And when you look at what happened, only about 5 or 10% slowly grow over the course of a year or two. And when they slowly grow, you can take care of them. About 1% of them will develop some little lymph node metastasis around the thyroid. But if we take their thyroid out yesterday, guess what's the risk of them developing a lymph node metastasis over the next 5 years? Same 1%. Doesn't change. It's outside the thyroid before we do anything about it. And so when we look at what's happened from 2012, we took a lot of grief at Memorial for opening up the first observation program outside Japan, with critics saying it will never work, patients will never agree to do this, nobody in the United States will do this. It took about 5 minutes, and people around the United States and the world found out we were willing to watch, and they began filling up our clinic in the active surveillance program. My favorite patient was a lady from New Jersey that had been flying to Tokyo for 10 years once a year because they were willing to do her ultrasound. And when she flew over there, Akira said, you know, you can just go across the bridge in New York and we can do it. So she's followed with me for another 15 years. If you look at all the data, these are summary data and meta-analysis and all that kind of stuff. The overwhelming data from all over the world that shows in these properly selected patients, watching is feasible. It's associated with almost no morbidity, no mortality. Distant mets almost don't exist. And more importantly, if you progress, it's safe and effective. Now, some of you guys that already decided to have surgery, you're still going to surgery because you're like, yeah, but it says 0.1% something bad can happen. The ones that are on the fence that said, well, maybe I needed more information, now maybe sort of saying, okay, that sounds a little bit more reasonable to me. And in the newest set of guidelines that I'm actually not involved in this one, these are the American Thyroid Association ones that were published just last year. Now they say the active surveillance may be offered as appropriate management for papillary microcarcinomas less than 1 centimeter. Which means when you see these ladies and men with papillary microcarcinomas less than 1 centimeter, you now have to have the discussion with them of watching or surgery. We all have to learn and get used to that. Doesn't mean you have to watch if you're not comfortable with it, but you have to let them know that there are other people that will. So in the new guidelines now, that's where we are. What does it look like if you decided to watch with me? No more needles, no more ultrasounds, no more needles, no more biopsies. We do an ultrasound about every 6 months for the first 2 years. Not because anything rapidly changes, but on the ultrasound, when you're trying to follow nodules less than 1 centimeter, the repeated measures variation is plus or minus 3 millimeters. So it can be 7 millimeters one time, it can be 10 millimeters the next time. If you have one every 6 months, that gives you 4 data points. And over that first 2 years, you can figure out, are they slowly growing or are they stable? And so that's why we do that. We don't suppress the TSH. And then if it gets bigger than 3 millimeters, that's the measurement variation. We'll talk about surgery if we find any lymph node metastasis, or rarely about 5% of the time, the patients just change their mind and say, I just can't watch. This is a paper that we wrote a couple years ago. It's one of my favorite graphs. I don't know if it means anything, but I love the colors. I was trying to figure out a way when I'm seeing patients in clinic, and I actually keep this graph in clinic, to tell them, if you watch with me, what happens? So this is about 500 of our patients I've been watching for several years. And the gray is the measurement variation. So that's our plus or minus 3 millimeters, or I do 3-dimensional volumes, plus or minus 75%. And if you start watching with me, this is cumulative percentages. About 80% of the time, we'll still be watching 5 years down the road. That's where you're likely to end up. About 10% of the time, over the first couple years, that little place will be growing. It was growing before you met me. I just didn't know. It was just growing, and we both learned that it's growing. And this takes you to surgery, so we get it fixed. Then there's about 4% that grow much more slowly, and I can't tell for about 5 years or so. Then the one that everybody worried about was it had been stable and then suddenly grew over 2 or 3 years. We thought that would happen about 1 or 2% of the time, and that's what it is. It's around 1 or 2% of the time. These guys change. This is the pattern that was most interesting to me. They would grow, and then they would flatten out. The ones that were doing that is they met me when they were 4 or 5 millimeters, and guess where these things flatten out? 8, 9 millimeters. That tends to be, if they're going to stay on this gray line, for reasons that we don't entirely understand, where they get stuck is usually 8 or 9 millimeters. So if you come see me with your 4 millimeters, not only do I have to tell you to watch, I have to hold your hand and say, hang in here with me, because in all likelihood, it's going to grow a little bit, and then it's going to flatten out. Now, that takes a special kind of person to go, okay, sign me up for that thing. But in folks that are trying to avoid surgery, they feel good about it. And what nobody talks about is about 5% of these actually decrease over time. Now, when I first started taking care of these patients, I would come back in the room after 6 months or after a year, and I would say, good news, it's stable. And they would look disappointed. I mean, what? I know I got a bad Kentucky accent, and I'm dealing with a bunch of Yankees, but I said, stable. And then a few of my really nice patients said, can you stop saying that? Because I've been working for 6 months to make this go away. So you've been doing what? So I sent my nurse practitioner back in there. I said, find out what the heck they're doing. They're doing every Chinese herb I've never heard of. They're doing every Indian product I've never heard of. They do something called exercise I'm unfamiliar with. They change their diet. They are treating themselves. So I quit calling these guys my observation program. They haven't rejected therapy. They just rejected my therapy. And many of them will be very disappointed if it stays stable. So I try to convince them if they weren't doing that, it would probably be growing because it makes them feel better and makes them come back to see me. And we've looked really hard at this group that got smaller. We can't figure out why. Some of them that got smaller were they sat on their couch and they drank beer and bourbon and it never changed. And their wife drug them in to have their ultrasounds and they were getting smaller anyway. But we're still looking at that group. Now, if you're still thinking about surgery, the other thing you have to understand is this uncomfortable truth that bad things happen in the operating room. Now, in thyroid cancer, we've learned that volume makes a difference. It's a surrogate for experience. Now, I know some surgeons in the United States that are really high volume bad surgeons. They are consistently bad surgeons and they have very, very nice websites. So volume doesn't always coordinate with being a good surgeon, but it always does in Virginia and here in Hamptons because I want the surgeons to invite me to their meetings. So if you look, so if you say, well, if I do a total thyroidectomy, this is low volume surgeons. 24% of the time you'll have a complication. Hypoparathyroidism, damage to a nerve. 24% of the time. And the reality is in the United States, the vast majority of patients that get a thyroid surgery get operated by a surgeon who does less than 10 a year. Not here and not at our centers. But people that grew up where I grew up, out in the mountains of Kentucky and all over the United States, they are not going to high volume surgeons. So if you're sending one of those patients, 24%, at Memorial, it's 15%. That's still a bunch. And maybe they used to say, well, we'll only take out half a thyroid. And very cleverly, you get half the complication rates, which is still 7, 8, 9%. So for a disease that's not going to hurt you, and for a disease that may allow you to watch and avoid a surgery, you can see why this balance comes in. Now, if you can think about what I've tried to tell you over the last sort of 30 minutes or so, this is a hard discussion to have with patients, right? For the ones of us that do thyroid, when we just try to talk a Graves patient about pills or radioactive iodine or surgery, right? That's a complex decision with three things. So as we've been sort of looking at what I'm doing in practice, what I'm really doing is we're looking at what's their potential risk. So what's the risk from the cancer? So we would talked about what's the risk of the cancer. What's the risk of the therapy, which is the surgical risk? And then importantly, what's the risk of delayed therapy? In some cancers, delayed therapy is disastrous. You're not going to delay pancreatic cancer, anaplastic cancer, probably medullary cancer, right? So in the little ones we're talking about, it's fine. And then what are the potential benefits? Benefits of therapy and the benefits of delayed therapy. You know, part of the benefits of delayed therapy is maybe you never get a surgery, but the other benefit is if you do a surgery, we're probably better informed to tell you what surgery to do. Most of these patients that I've watched, about 10% go to surgery, and the vast majority of them just get a lobectomy. Because we've watched the other half of the thyroid, we've watched their lymph nodes, we know the natural history of their disease after 2 years or 5 years, and you feel really comfortable saying, okay, for you, you want something done, here's what you need to have done. Or these days now, thermal ablations, where we take needles under the ultrasound and heat up the tip of the needle and just destroy that little thyroid cancer, leave everything else behind. You feel more comfortable doing that after you've watched the natural history of the disease. When we sort of figured out how we were going to roll this out in the United States, because when you just do it at Kuma Hospital in Japan, it was 11 docs. It was like a good old boys network, and they all knew what they were doing. But when we were going to teach it here in the United States, after the first 100 patients, J.P. Brito's one of my thyroid cancer fellows at the Mayo Clinic now, we sat down and said, what are the information that we're using to help make a decision about whether we're going to watch with active surveillance? It's the same paradigm. You can decide whether or not they need surgery, whether or not they do a lobectomy, lots of reasons. And it falls down to, for us in cancer, what are the tumor characteristics? If it's growing out the side of the thyroid, if it's already the size of a baseball, you're not going to watch that, right? What are the medical team characteristics and patient characteristics? And we divided those up into kind of ideal, appropriate, and inappropriate. So I would go into the room and I'd be thinking in my head, I've already seen your ultrasound. Based on the ultrasound characteristics, you're a good person to watch. If it grows a little bit, we'll be able to fix it. Medical team, it's easy. We were the first in the United States to do this. I've got phenomenal ultrasonographers. I've got all kinds of wonderful people. That was great when I had about 600 people on trial. They were all coming back to see me, and then this little thing called the pandemic happened. What do? I can either send them all to surgery, or I can go, okay, get a local ultrasound, please God, please God, please God, please God. And so many of these patients switched over and started using local ultrasounds in our regional area, and it actually worked out just fine. Nobody got hurt because we were looking for big changes at that point, right? So this idea that you can only do this in high risk places, I think we got to get rid of. Some of the details, it's papillary cancers, less than 1.5 centimeters, really confined to the thyroid. These are just some examples. So here's a papillary cancer. You can see the black right there is the cancer. If I watch that and it gets a little bit bigger, not a problem. You're still well within the thyroid. We can fix that. This one is sitting up front. It's already growing. The front of the thyroid is right here, and that strap muscle's in front of it. It's already growing outside the thyroid. It's 7 millimeters. That one's telling its natural history. That one probably needs to come out, right? We should do something about that. You get a few of these up here in the isthmus. The isthmus is really tiny, and the windpipe sits right behind it. Not a lot of watching in that area. So characteristics of the ultrasound will tell us. The medical team characteristics were interesting because I first started saying you should only do this in a really high productivity factory, a big ivory tower, that sort of stuff. And then when I got to thinking more about sort of the complications of surgery, if you have somebody that doesn't have access to really high quality ultrasonography and experts, they probably don't have access to a high quality surgeon. So would I rather let somebody have a thyroid cancer grow a little bit or send them all to surgery and give them the complications of the surgery? Kind of made us rethink about it, right? So when I now begin to think about rolling this out worldwide doesn't have all the access that we do. And I'm still thinking in right scenarios, it's still the right thing to do. Now, the patient characteristics, I'm winding down toward the end. Patient characteristics were really interesting to me because I didn't really understand patient characteristics. So I'd walk into the room and I would have this 30-minute discussion. The consults are usually 4 or 5 people when they come to New York. They have their mother, their daughter, I was going to say mother-in-law, but I don't think anybody, no, nobody's ever brought their mother-in-law. But they come, and there's a whole family. I answer all the questions, and you know how you can feel the visit's kind of coming to an end? It's kind of winding down, and I go, okay, it feels like we've made a decision. This half of the room says, cool, see you back in 6 months. And this half of the room says, how fast can I have surgery? They all heard me say the same thing. I answered all of their questions. And that happened over and over and over and over again. I was telling that story. I was giving grand rounds up at Harvard, probably, good Lord, this is probably 2013, 2014. And I was telling those anecdotes because I was really puzzled by them and just sharing it with a group of very senior doctors to try to help me figure it out. And Pam Harpsman is an endocrinologist at Harvard. Have you guys seen her work? For the young people, this is a book. It's paper and that kind of stuff. The good news is you don't have to do that. You can just look up on Google or YouTube or something like that. Pam and Jerry have given lots of these lectures around the world. And what Pam talked about was how people made medical decisions. And so after I lectured, I was meeting with her. And when I met with her, she said, hey, we just wrote this book and it resonates with what you're talking about. And so Pam talked about people that were maximalist and minimalist. You already know what you are from my talk, right? Surgeons are generally maximalist. If you had to guess, am I a maximalist or a minimalist? That's easy, right? I'm a minimalist, right? If I wasn't a minimalist, I probably would have never started this program in 2012, right? Because it wouldn't have resonated with me. That wouldn't have been something I would have done for my mom or my dad. And then there were, and this works not just in thyroid cancer, but everything. Naturalism or technology. The people that watch are naturalists. They want to treat themselves. They're distrustful. They think everybody has a complication. The people that want surgery say, just give me the fanciest surgery. Do the remote access. Do it from behind my ear. Do it from below my breast. Just don't leave a scar on my neck. They're sort of into that. And then believers and doubters. Believers believe in the medical system. They're my wife. My wife can't imagine one of you would hurt her or one of my kids. And I keep going, well, I testify in a lot of trials. It's not entirely true. And then there's doubters, right? And so as we begin to think about these guys, then I realized it wasn't just the patients. It was the patients, but it was also their family members. I remember I told you 5% of people that started watching changed their mind in the first couple of years. The most common reason they changed their mind is their daughter, their mom, their dad. Every visit it comes up, they talk about it. It's not them, they want to watch. And other team members. We realized we had to send a note to their primary care doctors. And we had to send a note to their other specialists that said, no, your patient didn't misunderstand. They're not in denial. They do not need a cancer now. I learned to frame the note that says surgery is just not necessary now, leading them on to think that I would do a surgery at some point in the future, even though I had no intention of doing that. And so we just say not necessary right now. And so if you looked at the ones that had immediate treatment in our group of 850 maximalists, they wanted the best surgeon to do it, and they believed they'd be cured and walk away from it. And my active surveillance group are minimalists, without a doubt. We've talked about this so much. There's not a week that doesn't go by when I walk into a room to see a new patient interested in active surveillance. And I say, hi, I'm Dr. Tuttle. How can I help you? And they say, you need to know I'm a minimalist. I've seen your video. To which I go, this is going to be a 5-minute appointment. That's cool. Get out of here. Come back and see you in 6 months. But what that means is there are actually more than one right answer, right? If I'm willing to say, fine, you can do surgery, and fine, you can follow with observation, there actually are 2 right answers. And then you have to sort of dive in and say, what is it about that patient that makes him choose one way or the other? And that led to this last column over here that we've called patient values, priorities, and goals. If your goal is to get that cancer out of your neck, it doesn't matter what I tell you about watching. That's it. If your goal, like me, is to preserve your voice and not trust surgeons, you're going to have a lot of talking to talk me into surgery, right? So I've given up trying to convince maximalists to watch. I've given up trying to convince minimalists to do surgery. And I've sort of said, okay, here's what I understand. Even when patients try to make it my problem, and they often do, because they'll say, look, we came up, we want you to tell us what. I'll frequently say, well, I think you should watch, but here's why. I'm hearing you say you're not really interested in surgery. You're afraid that if you take the thyroid out, you'll gain 100 pounds. You're not going to feel good on thyroid hormone pills. You don't have time right now. There's a bar mitzvah or a wedding. There's something going on. So I'm hearing you say that's what you value. And if they say, yes, you're right, cool, we got it. Every once in a while they go, no, that's not what I'm thinking. And then they help me understand that. So we've moved with Louise Davies to move away what has been called shared decision. And Louise Davies, which is a surgeon from Dartmouth that's now in Wisconsin, Louise called this guided. And it came up, I was up in Dartmouth where Louise is, and we were talking about, they hike everywhere. This is actually the trailhead from the parking lot of Dartmouth Hospital. You don't have to drive anywhere to go on a hike up there. You just walk past your car and go on a hike. And it led to this idea that maybe what we are is the model is more of a tour guide and a traveler. The doctor's the tour guide and the patient's the traveler. My wife and I love to hire tour guides, and we go to various places all over the world. And what's the tour guide want to know? Well, he wants to know, how old am I? Am I bringing the grandkids? And can you climb mountains? What am I interested in seeing? I want to know from them, what are the options that we have? What are the things that we can see? And then the idea is that the traveler or the patient shares their values. I help them incorporate that into say, the tour guide may say, I know you want to see that, but you have to climb a ladder 100 feet straight above your head to do that. To which I'll go, maybe not a good idea. That's maybe not for me. Or maybe I want to go someplace and the tour guide goes, honestly, this is not the time to go there. There's a lot going on right now. I know you want to go to Puerto Vallarta, but maybe this weekend's not the right weekend to go to Puerto Vallarta, right? That's just the reality of the situation. And that understand that we're going to start this journey together. I see it very much as a journey of both the patient and, because the tour guide doesn't just give you a map and say, go, right? They walk with you, understanding that the journey may need to change as we walk our way through the pattern. And so what that left us with was this final thing is what we put in the New England Journal. That when I walk into the room now, I want to make sure I convey to the patient, what are these risks, cancer therapy and delayed? What are the benefits up front and benefits of delayed? Understanding what their values, priorities, and goals. And if you want to do some really cool research in relatively small places, it's right here. We don't have a good way of finding out what patients' values and goals are. The current PROs and stuff that we use, they talk about complications, but understanding within the context of thyroid cancer, thyroid nodules, diabetes, what are the priorities and goals that we need to be asking about that are realistic, totally open for research. And then that allows us to guide the thing. The model that we're going to show in here, I had 2 boys that were musicians. Thank God they grew up and got a real job, got off my couch. But for about 10 years, they were aspiring musicians in New York City, which meant my basement was full of electronic stuff that I barely understood. But I understood their mixing board, because I knew how to turn the volume down. I didn't know how to mix, but I knew how to turn it down so I could listen to the Kentucky basketball game. And our idea was, if I gave you a model that looks something like this, and you walked into the room, and these are faders. So just like you would move up and down to make something a little louder, a little smaller, to this is our papillary microcarcinoma. And the risk we're talking about is what's the risk of dying of thyroid cancer. Cancer risk, really low. Therapy risk, really low. Maybe a little higher than the cancer risk. Delayed therapy, really low. Not much benefit to treating right now, some benefit to watching. And if the patient was a minimalist, that leads you to active surveillance. So I find myself sitting in the room with the patient, making sure I've checked off all of these little things. And in the article, they'll pretty this up where it looks nicer, but there'll be a blank one in there that you can kind of help the patient walk through. And I find the patients now helping me adjust. I love it because I'll paste these into my Epic note. I'm going to probably stop doing that because now I get feedback that says, I think this one should be on the 4th line instead of the 3rd line. I'm like, no, don't stop. So if I come back to you, so now you've got the whole picture. You've got an idea that this is probably an overdiagnosis. You've got the option of watching. And by understanding what your priorities are and where you are in life, a lot of people use my watching program as a bridge to a better time. They have no intention of watching for 20 years, but they're waiting for other technologies to develop. They have weddings, they have the safari that they've been waiting their entire life to go on. And just knowing that they have time to watch and think about it in cancer is kind of amazing. So at the end of the day, I think that no matter whether we're dealing with thyroid cancer or anything else, we have to understand the natural history of the disease. Don't take credit for the natural history that's not going to hurt somebody. What's the natural history? What's the therapeutic effectiveness of what you're about to do? How does that impact the natural history? What are the risks associated with what you're going to do? And then integrate that with patient values. And that will let you, in good situation, deal with sort of therapeutic equipoise. And what I find is the patients feel good about it. I feel good about it. I feel like we've got a good shared understanding. And they understand that we can change our mind as we walk through the journey. And we'll go from there. Thanks very much. I'll stop there. Questions, comments, rebuttal?
Excellent. So I think we've got some time for questions. If people have questions, please make sure that you press the button in front of you and make sure we can hear you. So questions from the group, Dr. Thompson?
Hi, Dr. Tuttle. That was a great talk. Thank you. I had a question regarding molecular and genetic testing. Often we now get data back from ThyroSeq and Affirm and all these places about, you have a Bethesda 5 and they give you the mutations that are there now. Do we have any data on using that to help us further determine the risk when we're doing active surveillance?
That's a great question. So the question is, when we're dealing with thyroid nodules, we frequently do molecular testing of the nodule to help us understand what the driver mutation is. And the question is, how do you integrate that into your decision making? It turns out in these small papillary microcarcinomas, it hardly integrates at all. That even BRAF positive, which is what we all worry about, their outcomes are exactly the same. It's because you're trying to find the most aggressive goldfish in the bowl. These are all really, really low risk, and you're trying to risk stratify in there. So we don't require molecular testing. If it's there, I don't ignore it, but it doesn't really change my recommendations. The only thing, every once in a while, you'll get one that's 1.5 centimeter, and it's got like 3 or 4 mutations, right? BRAF plus TERT or P53. Those are really unusual to see what otherwise looks like low risk. But if we had one of those, I would move them to surgery. Otherwise, just the typical risk factor. The reason for that is if they, in all likelihood, they may grow a little bit more than the ones that don't have it, but they're still going to grow so slowly, you're going to pick that natural history up. It may well be that the ones that grow in 2 years have a little molecular profile that would suggest they grow a little bit earlier. We've spent about $500,000 trying to find that molecular profile with Fagan, and we can't find it yet. But again, we're trying to predict such a low risk event. Your tool would have to be really, really good.
Thank you. And Dr. Waldholz?
Just a comment from the viewpoint of a high-risk patient from 26 years ago, and it really resonated with what you said. Number one, you were still in training, so I went to MD Anderson. Number two, I picked my surgeon, a guy named Robert Udelsman,
Absolutely,
who spent his entire life as chairman of surgery at Yale, at only doing malignant thyroids. Before that, he was at Hopkins, and the head of ENT at Hopkins told me, he is the guy I want to operate on you. Number three, radioactive iodine is not benign. You can get sialadenitis it's like having pancreatitis of the face. You've had that once or twice. So it's really important that those things are not benign. The other thing is post-op, you have to have a TSH of about 90 before you can take the radioactive iodine. And I can tell you, all my doctors were saying, what was that like? And the answer was, even your hearing is not right.
Yep.
It's very hard to describe. And the other thing is, before we had Thyrogen, and that is a bizarre thing because in 12 hours, it takes your TSH from normal to 90 and you throw up. It's a very weird experience. But the disruption in people's lives having to go off their thyroid medicine, and if you've committed to surgery and radioactive iodine, then it's going to take you a good 6 months to get back where you are. And finally, where you keep somebody's TSH, walking around with a TSH of 0.05, you really are always hot, really uncomfortable for about 10 years until they finally realize maybe they're going to give you AFib and they're going to cut that out. So just wanted to share that experience of the things you can do to people, but this needed to be done. It was a largely
Yeah, absolutely. I mean, and understanding those, it's actually, I've been at Memorial for about 10 years. I'm the world's expert on dry mouth and sialadenitis and blocked tear ducts because I trained under really aggressive docs. We gave a ton of radioactive, and part of my sort of drawback was after 10 years, I was seeing people having their teeth all fall out, gum disease, really major complications. So when you do something wrong 80 times a week for 10 years, it doesn't take you long to see those side effects. And that was a large driver. And my patients were nice enough to share that with me in sort of beginning to de-escalate. And so how do we talk to that? And how do we balance that? Yep.
Great talk. I'm like you in terms of watching how the thyroid cancer arena has evolved. I remember listening to Ernie Masaferi, your Ridgeway. And the most interesting thing actually back then was Ian Hay from Mayo, who was the only person who was a minimalist, but everybody was kind of laughing at him because there was no real data, but he had a hunch and he was advocating that. At the Cleveland Clinic where I trained, almost everybody got total thyroidectomy. Almost everybody got radioactive iodine treatment. Almost everybody got 100 plus millicuries dose. And then that was withdrawal. So I think I'm kind of witnessing the evolution for the right reasons that you all outlined. So that said, coming to patients, and I have to admit, I haven't practiced the minimalist way, the way you outlined it. From limited conversations I get with patients, there is this underlying knowledge in our society that cancer is bad. It has to be out. As you said, you mentioned this mechanistic trap or whatever. People have that logic.
Very much so.
And I find it sometimes very difficult to convince patients. So what percentage of your patients end up accepting the minimalist approach versus...
So if you look at what percentage of people across our entire center accepts the minimalist approach, it's about 50%. So it's the same as what Akira showed in Japan forever. If you ask in my personal practice, it's about 95%, because that's why people come to see me that like shouldn't be watching. So it'll be that bias. So yeah, even in groups like Anna Saka's group in Canada has tried to do some upfront teaching and it doesn't change that very much. I will tell you, at least in New York, this idea that every cancer has to be treated right now is starting to give way. 10, 15 years ago when we started this, that was the biggest thing that we fought. Now we'll often hear people, because we've got CLL patients, some other patients that we're still treating. So it's breaking a little bit where folks are a little bit more open to it, but still difficult.
I think we have time for one more question. Dr. Shah?
This was a great talk. Thank you. As someone interested in like metabolism and whole endocrinology, I was wondering if there were any comorbidities that might be playing a role, or let's say pregnancy or menopause that plays a role in how affecting the natural history.
That's such a great question. So the question is, are there other metabolic issues or pregnancy that affects the natural history? That's exactly the way to ask that question, right? Because I published papers years ago that said if you get pregnant, the cancer gets a little bit bigger. And then I had about 10 or 15 patients that I was following with active surveillance, papillary cancers. I'd had 8 or 10 ultrasounds before. They got pregnant, and then after pregnancy, it was a little bit bigger. But when you charted what their natural history of disease was, it's exactly what I would have predicted. Pregnancy had nothing to do with it. I fell for my own trap. They just happened to be pregnant while their thyroid cancer that had been growing all along had been growing. So now we're writing papers that say in the pregnancy setting per se, rarely a little bit of stimulation, but not much. It looks like the natural history. Almost no studies that have looked at metabolism or sort of, I mean, you can make the case that insulin drives these things, and we know other cancers respond to insulin. So looking at, and it may well be that what you'd do is you'd see what their pace was, do some intervention and see if it changed, right? They have a doubling time of 5 years. Maybe you do some intervention and the next 4 values gives you a doubling time of 10 years. Doesn't mean they have to shrink, but you change that natural history. So we're looking at natural. We just did it for GLP-1s. So we've got 2 papers coming out. One in my active surveillance patient, about 25 or 30, that I had their doubling time, their natural history on and off GLP-1 agonists, no difference whatsoever. And about 500 patients that were treated, 500 that weren't, no difference whatsoever. Again, asking that natural history question.
Excellent. Well, thank you so much, Dr. Tuttle, for joining us. And thank you, Dr. Comron, for nominating Dr. Tuttle to join us. Thank you, everybody.